Welcome to Equal Dose, the podcast that delves into the factors shaping our health and explores how we can create better, more equitable outcomes for everyone. I'm Matria Godfrey, joining you from Washington, D.C. In each episode, we address pressing challenges in health equity, sharing expert perspectives and inspiring stories that drive change for a healthier world. Today, we're looking at rural health with a focus on the opioid epidemic. We'll be talking to Dr. Sarah Kattakuhzy, CESAR Director of ARTEMIS from the University of Maryland, and Dwayne Dean, Supervisor of the Peer Recovery Specialists for Heal Together and PRISM Studies. But first, we want to make this disclaimer. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition they may have and should seek the assistance of their healthcare professionals for any such conditions. Now it is my pleasure to bring in Layla Rizvi, the Director of Strategy and Research at WebsEdge, the company behind this podcast. Layla's joining us from across the pond today. Layla, how are things in London?
They're good, thanks. Yeah, very well.
Wonderful. Thanks for being with us. All right, I want to talk about rural health and how big of a problem are illnesses and sickness in these rural areas.
So we're talking quite a big problem. 1 in 5 people in the US live in rural areas, and they have a far greater risk of sickness, whether that's heart disease, diabetes, and particularly substance abuse. They have a significantly lower percentage of use, but much higher incidence of mortality when it comes to substance abuse. There's a lot of factors here at play, but it makes you think that how neglected are the rural areas in the US, and why are we not talking about them enough?
Yeah, I mean, you're right. And it's interesting because typically I think the mindset has been you think of inner city, metropolitan areas as being more affected by drug use. But the numbers that you're seeing in those drug overdose numbers in particular are completely contrary to that.
Yeah, absolutely. And it makes you think that, what is the issue at hand? Is it infrastructure? And is it something that we need to tackle from that perspective? And who does that require? So is it community health workers? Is it a physician's shortage? Is it, just not enough roads to, take people from one place to a place of care? So I think it's just far more convoluted than you might think. And there are a lot of actors and specialists that need to come together to address it. The majority of the US is rural. And so even in popular media, our rural communities that make up the bulk of the United States completely neglected. It's just much more than just a medical shift, a infrastructure shift, but also a cultural shift to how, we approach rural communities.
You're so right. I mean, I do think we usually think of the big cities where there are more people, a more dense population as needing more of the attention and more of the opportunities. But, like you were mentioning, there are so many barriers to healthcare when you're talking about these rural areas, whether it's hospital closures or less likely to have insurance, maybe because of the costs associated with it. A lot of these residents use telehealth because they don't have, like you were talking about, the physicians nearby. But there are a large portion of those who live in those rural communities without internet access. What do we need to do? There's also, we talk about food deserts and access to fitness centers or gyms. Lots of different things, like you said, needs to come into play in order to try to tackle that problem, all those problems. And that's something that we're certainly going to get into today with all of our guests.
Yeah, absolutely. And I think it will just be interesting to understand, is it just the basics? Is it just simply, more physicians? Is it a resource issue? Or is there something much bigger and more challenging in the hierarchy? What does it look like? Where are the bottlenecks? Why is this not being solved? If it is just quite simply, we need more roads, we need more hospitals.
So really excited to have all of our guests today. We're going to really get into polysubstance abuse. In particular, we're talking about the opioid epidemic, kind of like what we were just mentioning about, the issues in rural communities versus in, dense populated cities. 45% higher the opioid overdose rates in those rural communities compared to cities, which is huge number. And young adults between 18 to 25 who live in these remote rural areas misuse methamphetamine almost 2 times the rate as those in urban areas. So when it comes to addressing the polysubstance abuse and the trends, it'll be very fascinating to get into that with our guest today. So here to dive in a little deeper now is Dr. Sarah Kattakuhzy, Associate Professor at the University of Maryland School of Medicine, along with Dwayne Dean, Supervisor of the Peer Recovery Specialists for Heal Together and PRISM Studies. Our thanks to both of you for joining us today.
Thank you so much for having us.
Thanks for having me.
Certainly. All right, Dr. Kattakuhzy, I want to get started with you. Can you tell us a little bit more about the ARTEMIS project and how it's working to improve substance use care?
So the ARTEMIS project is a very long acronym, but the words are really focused on polysubstance use in rural Maryland, and delve into why that's a challenge. But the goal of ARTEMIS is really to bring lived experience, so the patient voice, so people with lived experience, to bring their perspectives into research at the inception so that research and clinical care around polysubstance use in our state is reflective of the real needs, thoughts, and desires of the people who are most affected. So that's, I think, very important to contrast how research usually happens, which is in, quite frankly, the ivory tower of academia. You usually have folks like myself who are thinking of ideas that may or may not be informed by lived experience. And so the National Institute of Drug Abuse, or NIDA, very appropriately put out a funding call to build patient-engaged resource centers to really try and tackle this issue and this problem that we have in a lot of science, which is doing science without talking to the folks that are most affected by the results. So that's how the ARTEMIS project came to be, and we're really excited about it.
And just to kind of give us an idea, how big of a problem are we talking about when it comes to polysubstance use in Maryland?
Yeah, unfortunately, what I'll say is that almost all substance use now, whether it's intentional or unintentional, is polysubstance use. We have an incredibly contaminated drug supply in the United States at large. And I believe that our region, the Mid-Atlantic, is particularly hard hit. There are a number of contaminants such as xylazine or medetomidine. These are a couple of the contaminants that have just, more recently been infiltrated into the supply. But there's also, a lot of shift in drug use patterns that are like any other industry that are affected by the economy, by supply, etc. So there's now a greater likelihood of drugs having something other than the drug that the person is aiming to use. So polysubstance use refers to, I think, to some degree, someone using one substance and it having multiple things in them. But there's also a separate phenomenon of polysubstance use, which are individuals who are trying to engage in more than one drug, either synchronously or asynchronously. And there are certain patterns or regional patterns associated with that. We see a lot of polysubstance use in rural areas, in Maryland in particular.
Dwayne, I want to bring you in. You are an internationally certified peer recovery specialist. Tell us a little bit about your journey, about how you became to, be this specialist, and also what led you to becoming involved in Heal Together and PRISM studies.
So I'm a person in long-term recovery. And what that means for me is that I haven't found a reason, need, or excuse to use any minor mood-altering substances for about 11 years. But that comes after about 27 years of active addiction. Wow. So my experience with active addiction, my experience with recovery, and my experiences with recovery support. I was sought out through the University of Maryland. I was actually working for the University of Maryland Hospital, the medical system, as a peer supervisor for 2 of their hospital locations. And I started doing some part-time work in one of the studies that they were doing, University of Maryland College Park Global Mental Health and Addictions Program, which is a partner of CESAR. They were doing a study in Baltimore City, and I filled out for a part-time position, and I started doing work with them, and it just continuously progressed, and I started doing work with the Heal Together study and the PRISM studies.
Wow. Well, congratulations on your 11 years. That's absolutely remarkable. That's awesome.
Thank you.
Dr. Kattakuhzy, I just want to bring you in here now and ask more about rural areas. And what is it about rural areas which have made them so susceptible to kind of polysubstance abuse and kind of the disparity that we're seeing in rural areas compared to urban areas?
Rural areas are particularly vulnerable to changes in drug supply. That is, I think, in part because of how challenging transportation is in that area. So, for example, most drugs are going to come into the United States through, major cities. And, for example, Baltimore, the city where I work in, is a major seaport as well as a major transportation hub. And then it goes, distributes from there. And so you can imagine that cities and regions that are rural that have really only one or two of the main roads that are going through them are really just getting whatever supply is available to them is sort of transported to them. So I think that's one challenge that rural areas face is a limited supply. And so what that leads to is a lot of creativity to meet the needs of people who use drugs. And so they're going to reach for solutions that are, maybe outside of what their first choice is, but that's going to keep them safe, keep them out of withdrawal, and maybe keep them from using other substances. So they may, for example, combine a few different types of substances that are available to them, or they may smoke a substance that they normally would rather use in a different mode. So I also think that there are normal patterns of use that establish themselves in certain geographic areas. So there may be, for example, in the region, some of the regions that we serve, there's a lot of combined methamphetamine use alongside opioid use. And that just seems to be a regional choice. There are many people who are using drugs communally, and they may be sharing that. Again, maybe a supply issue, which is not to say that that doesn't happen in urban areas. I want to be really clear. Polysubstance use is an issue all across the United States.
Dwayne, I want to come to you to delve more into the detail of kind of rural areas and what makes them so challenging when it comes to substance use treatment. And could you explain how PRISM is aiming to address this?
So some of the things that Dr. Kattakuhzy just mentioned are some of the challenges. Some of the challenges in the rural area would be a lot of social determinants. It could be around transportation, provider availability, all the different social determinants, things that determine the wellness of a person, where they live, work, and play, and their ability to thrive in that environment. So with the rural areas, we've been able to identify some of those challenges as far as provider availability, as far as transportation. I was really amazed to find out that we were doing a study. There was no Uber. Like, there's no Uber. I thought Uber was everywhere.
Yeah.
It actually isn't, But those are some of the things that became really challenging. And the work with PRISM is you have the provider side where they are supporting people's substance use disorder, opiate use disorder, polysubstance use, with means such as medication for opiate use disorder. But then interwoven in there, you have the intervention, the peer intervention. And that intervention it supports the participant with resources. It supports them with addressing those barriers to those social determinants so that we can help them thrive in their process of recovery. And those are some of the things that PRISM, so it's about adherence and retention. And we're understanding that people actually want to be well, but do they have all the resources? And I think the peer intervention part helps to address those barriers, those challenges.
People want to be healthy. They don't want to suffer from polysubstance abuse. And I think that awareness of that from communities as well and getting rid of that stigmatism, so important.
Dr. Kattakuhzy, you mentioned at the beginning the importance of listening to and engaging those people who have a lived experience when it comes to treating this. Dwayne, can you kind of explain the role of a peer recovery specialist, and also how does that experience of someone who has dealt with this in their past, how does that help the person that you are trying to assist?
Just for example, you've caught an Uber before, right? If you catch an Uber, there's some things you have to put into the app. You definitely have to have your bank card or debit account attached to the app. The next piece of information you need to give them is where you want to go. So peer recovery support is simply just like catching an Uber. We meet you where you are and take you where you want to go. So it's not a predefined way to tell you, oh, you should recover this way, you should recover that way, you should recover the way that I recovered. I meet you where you are and I take you where you want to go, even if it's not that far. I support an effort towards change, however that may look for someone. And it may look very different for many, and that's pretty much the essence of peer support. It's self-directed, it's person-centered care.
Dr. Kattakuhzy, how much of a difference do you see when it comes to the success of these programs when you employ that peer recovery specialist versus when you don't have that?
Oh gosh, I can't say enough. There's no comparison. I consider myself to be a really empathetic and knowledgeable physician, but there is so much bias and so much challenge that I bring, and that people who've gone through the medical system and really been harmed by the medical system, the challenges they bring to a therapeutic relationship. And I think one of the most beautiful things about the peer relationship is that it can really start on an equal footing, and that the peer recovery specialist says, I've got you, I'm here to hold your hand, I'm not here to judge you in any capacity. And I say that to my patients, but I can tell you from just anecdotally, I've had a patient who said, I relapsed, but I didn't want to come back because I didn't want to disappoint you. The structure of the medical system does create walls. And it's our job to open them as much as possible. And I think that peer recovery specialists are the ideal way to be able to bridge that gap, because we're all unified. The patient included wants their most healthy way of living. They want to live their best life. They want to, for whatever way that looks like for them. And so just some of the differences I've seen are that, there's a lot of unaddressed stigma when you don't have a peer recovery specialist. There may not be an integration of addressing social determinants of health or other things outside of just picking up the meds and taking the meds and coming to the appointments. So all the other contextualization of a person's life is being addressed when you have a peer recovery specialist. I also want to say that peer recovery specialists do not need clinician systems to operate in. Peer recovery specialists can operate independently. There may be individuals who are not seeking medical treatment, and peer recovery specialists can still serve a vital role in that recovery journey as well.
Dr. Kattakuhzy, I want to come on to more specifically the challenges with polysubstance abuse. Why is care more difficult or inaccessible for those who partake in polysubstance use?
Well, first and foremost, unfortunately, we do not have any FDA-approved therapeutics for many substance use disorders. So, for example, there are no FDA-approved treatments for cocaine use, methamphetamine use. This is really challenging because opioid use disorder, alcohol use disorder, tobacco use disorder, we have very efficacious evidence-based treatments that we know work. We don't have that kind of really solid evidence base for treatments and therapeutic options in the other types of substances and many other types of substances. So I would say that's one real challenge, and why polysubstance use is more complex, because sometimes you treat one use disorder, but your options for treatment are much more limited. So there's use of what we call off-label drugs. So there are drugs that have some evidence base but are not raised to the level of FDA approval. And there are also really good evidence-based, behavioral-based interventions that we can utilize for those other substance use disorders. I think the other challenge with polysubstance use is that co-use, especially use at the same time, brings out a different response within the body. So the body's physiologic response may be different, and there can be more danger in combining different types of drugs. There are not enough providers who are well versed in the treatment of multiple types of substance use disorders. So people who are board certified in addiction medicine or addiction psychiatry, there are very few of those providers, and we're not well spread out throughout the country.
I now want to come to you, Dwayne, and ask more about the additional challenges of polysubstance use, and more so what you might have seen from, the peer recovery support, and perhaps maybe from the behavioural side, which Dr. Kattakuhzy alluded to.
When it comes to peer support, it's more recovery focused, not disorders focused.
Yeah.
So we don't focus more on the different substance use disorders. So that would encompass the different substances. So again, we support a person's effort towards change or the lack thereof. So if a person may be getting treatment for one substance use disorder, but still you still actively using another substance, we meet them where they are. We help them to identify what could be problematic. We help raise discrepancy between their goals and then their actions or behaviors. Peer recovery specialists, we maintain our effectiveness when we preserve our role and stay in our lane. We offer non-clinical but professional support to the community.
Obviously, we're talking about polysubstance use here. So if you are, if you have somebody that you're working with, and like you said, they're willing to come off of one substance, but maybe they're not willing to give up something else, how do you address that?
A person has a right to recover at what rate, as fast as they want, if they want. They have a right to do that, and I support that effort. It's self-directed. And I've dealt with participants that was getting medication for opiate use disorder, but was still actively using other substances. And I said to one of them, I said, what do you want to be when you grow up? And he was like, what are you asking? I said, what do you want to be when you grow up? Do you plan on using the rest of your life? He's like, no. He was 21. He's like, no, I'll stop. I just feel like he felt as though he had all the time in the world to stop. I said, okay, so what do you want to do? And he said he wanted to own a gas station with a mechanic shop. I said, well, you're definitely going to need a state ID for that. Let's get your social security card, birth certificate, so we can get you a state ID. We simply asked them, what is your recovery goals? And we walk alongside them as they achieve those goals.
The thought process behind this methodology that as they stop using each of these substances, that they will start to realize life gets a little bit better with every substance that I stop using.
I can share my experience with it, with situations such as that, and be an example. I was a person that was that was on medication for opioid use disorder. I'm a person that used drugs. So I can share my experience with them, but I don't share my experience to kind of manipulate them into a certain pathway. I ask them, what do they want? What do they want out of their wellness? What do they want out of their life? And I support that. And it's done that way because the reality is, and I'm just using my own self as an example, when I wanted to intravenously inject heroin, no one could stop me, But when I was ready to stop, I had some people that was there for me, that was empathetic.
Yeah, it's a really fascinating way to look at it, that you've got the support system there and ready to go for when the patient makes that decision.
We're talking about patient-centered care, person-centered care, but also about harm reduction. In medicine, we practice harm reduction all the time. And all that says is that, yes, for every diabetic patient, your goal is that your hemoglobin A1C is less than a certain amount. But if you're not at that amount, we don't say you are no longer deserving of care. We try to maximize their health wherever they are. And that's the same when applied to people who use drugs. It's just that because drugs are illegal and because they're stigmatized, that we have a different lens on them. No two people are going to be on the same recovery journey at the same time, at the same place. That is the exact same for two diabetics or two people with hypertension or anything. any any thought that you could have in any field of medicine. I also think the same as of one person who's using two different substances. Those substances may come off at different times in their life, or their use may vary because they're utilized for different reasons.
Firstly, how do you think we go about changing that kind of culture when it comes to viewing drug addiction and drug abuse through the lens of harm reduction? Secondly, there's such an emphasis, especially nowadays, on choice when it comes to kind of any aspect of medicine, whether that's taking legal drugs and pharmaceuticals or vaccination. But why do we not apply this when it comes to kind of drug abuse?
I do think, and I would love to hear your thoughts on this too, but I do think it really comes down to the way in which people who use drugs are villainized, and the way there is, I think, a strong association because drug use is criminalized. Incarceration is a tertiary consequence of drug use. I don't have a single patient who has never been incarcerated in their life, maybe one or two, but it is part and parcel because of the heavy criminalization of substance use in the United States. So it becomes easy to view people who use drugs as criminals. And in the criminal legal system, we take away people's rights. We don't view them as whole people. And so I do think that there is an element of that in how we approach substance use disorder care. But I also think that, we in the US and in many parts of the world tend to say, well, you caused your own medical problems. Outside of this podcast, there's a lot of discussion of whether addiction is a brain disease or a social construct or all of the above. It's complicated, it's multifactorial, but I do know that when people are in their deepest parts of their addiction, that there is a strong component that they have to use. So I don't know that everyone understands, what's happening inside the brains of people who use drugs. They don't understand a lot of the pathophysiology of it. But I think most importantly, they're not humanizing people who use drugs as just people.
Yeah.
So I think that those are some of the challenges we're up against.
And I totally agree. I also believe that us as a people have to change the narrative. The stigma of addiction, the way that we view it. I believe we have the ability, and that's some of the things that peer recovery specialists do, is we look at the using more recovery positive language. We have the ability to change public perception. I was in a meeting and the guy kept saying, well, homeless person and addicts. And I'm like, no, it's a person that's experiencing homelessness. It's a life experience. And it's just an experience, and it's a person who uses drugs or who experiences substance use disorder. Yeah. The other part of your question about the harm reduction, we've been doing harm reduction forever. I can remember in the 70s, I got in my uncle's deuce and a quarter and couldn't even find his seatbelt. We didn't use seatbelts. I've never seen a child seat when I was that young. And we have those things. Even down to like the sports we play today or we watch, football players, they get paid millions of dollars to go and harm people and potentially harm themselves. But now we have better equipment, better pads, even rules on how you can and cannot tackle. That's harm reduction. That's harm reduction. And if we can get people to look at it, just as Dr. Kattakuhzy said, as far as the addiction being a disease, just like diabetes, or just simply the need for harm reduction.
Before I let you go, Dr. Kattakuhzy, I know, including those with lived experiences is paramount to the success of your program. I know that you're also creating the Patient Advisory Committee within ARTEMIS. What can you tell us about that?
So the ultimate goal is to have a group of approximately 15 folks who are people with lived experience or who've been affected by polysubstance use in rural areas. And what the goal of that patient advisory committee or that advisory committee would really be to serve as consultants to individuals who are in academia, who are in the clinical world, health departments, other spaces that intersect with people who use drugs, to really be able to consult on research and clinical care that's directed towards people who use drugs. And the goal of this, patient advisory committee is to make sure that the information that's being used to develop these projects and these programs will ultimately meet the needs of its consumer. So where we are right now is that we've kind of put a call out. We've asked folks from around Maryland to apply. We've had a really exciting, wonderful response. And we have to shout out the peer community, the harm reduction community, who's really elevated our call, and other groups that have been doing this work for a very long time, like the Maryland Peer Advisory Council. And so we've had folks from around the state apply, and we're in the process now of kind of going through those requests, and we're going to assemble our team of approximately 15 folks, and hopefully in Q1 to 2 of 2025 be able to begin meeting as a group and develop projects and serve as consultants and really create the next phase of this project.
Awesome. So exciting. So exciting. All right. Well, thank you both so much for your time today. And yeah, we really appreciate, all of your insights today.
So Autria, that was pretty compelling, huh?
Very. I think that, having that peer specialist component as a part of any type of recovery program, that lived experience is probably going to yield a lot more success when it comes to someone's recovery than, like Dr. Kattakuhzy said, someone coming in who has never experienced maybe the type of things that might lead someone to, polysubstance use. I think that the structure of their program is really fascinating.
It's meeting them where they're at, and also for someone who has suffered from substance abuse, the thought process is that no one can stop me, right? And I think having that peer recovery support for someone to be able to empathize with that feeling that, like, actually it's only me that can make the decision. And if I do make that decision, there is, support around me to then take action after that decision.
And I think also something that was interesting to me is, in my mind, I've always thought of, recovery being you're fully clean, like Dwayne, who is sober for 11 years now, which is absolutely phenomenal. But I think it's interesting that their program is like, no, if you are just looking to get off of one of these substances, like, we're going to help you do just that.
It's a stepwise process, right? And when we're doing anything, when we're trying to improve anything, it's one step at a time, one thing at a time.
Super interesting, a fascinating program that they have going on, and I hope that it sees wild success. Coming up next time on Equal Dose, we'll be looking at preventing violence in communities. If you've enjoyed the show, please make sure to like and subscribe. It really helps us to create better content for you. Thank you so much for joining us today and for all of your support. Until next time.
Goodbye.
Equal Dose is brought to you by Web's Edge. We'd like to thank researcher Maddie Horn and editor Abby Harries, our studio engineers Adam Dean and Sam Saris, graphics designer Matthew Coleman, and producer Kath Sheehan.